All right, so let's talk about COVID-19. So you guys all know COVID-19, nothing you have not heard of, right? I think you guys started pharmacy school in 2021, 2020? 2020, okay, just in time when we started COVID. Right, so was your first year virtual?
No, 2022.
2022, oh, 2 years later, okay. So you guys dodged that bullet. Okay, so on this graph, on the x-axis, we're looking at time, right? So essentially, just to show you the wave of like what percentage of people had COVID. So you can see, started around early in the US, started in 2020, right? So cases went up, down. So you can see like different waves, you know, so where we are today. It's not necessarily seasonal, so it's all year around. We get COVID, right? It's just that, you know, during times that people are, you know, sometimes this happens to be during cold season, but also during summertime, you know, when a lot of people come together, for example, when there were rallies going on or, you know, various things that happened over time, you can see like large peaks. But essentially, this is important because people have died. Over 1 million people in the US have died, right? So last time this was updated, almost 1.2 million people have died since it started in 2020. And hospital admissions, about 7 million people have been hospitalized. So it's a big deal, and this is the first time I'm actually covering this in the course, so it was not in the course because initially when it started, what was I gonna tell you? We don't have vaccines, we don't have treatment. And then, you know, in 2021, as we were having treatment was changing all the time. So it's like, if I covered in the course, by the time I talk about it and by the time there is an exam, it has totally changed. So it made no sense. And then, so today we have vaccines and we have treatments, and treatment is pretty stable. So, you know, we're including it in the course, and it's something that you will see regardless of where you go, you will have to deal with COVID. So it's good to have it in the course now. And that's why I say it's because it's the first time, I don't know, I could either finish early or we'll run over time. We'll find out today. Okay, so let's talk about coronaviruses first, right? So there are a ton of coronaviruses out there. They're not all necessarily bad, and they don't necessarily infect humans. There are only 7 of them that infect humans that we're going to talk about. In general, they are envelope viruses. They are positive sense RNA. So at this point, if you learn from hepatitis, for example, hepatitis C, positive sense RNA means that it's ready to go into a ribosome and start translating, right? It doesn't need to do anything yet. So it doesn't need to go into the nucleus. So all coronaviruses are like that. And they are classified into 4 genera, so alpha, beta, gamma, and delta. And for the beta, which where we're going to focus most, beta has been essentially broken into 4 lineages, so A, B, C, and D. And you don't necessarily need to know all of these classifications. I'm just trying to you know, show you how these things are organized. So with the alpha coronaviruses, there are a couple that we had talked before. These are, and anytime, because only 7 of them infect humans, so if you see a H at the beginning, that stands for human, right? So this is a virus that infects human. So these 2 alpha coronaviruses cause like a common cold. So, you know, not a big deal. We don't do anything. Like you have this, go rest, have some fluids, you'll be good to go, right? They're not gonna cause a whole lot of problems. With the beta coronaviruses, in lineage A, there are also a couple of the human coronaviruses that also cause mild infections like common cold. Again, no treatment needed. Go, you know, rest, have some fluids, you'll be good to go. The problem started with lineage B and C. So back in 2002, I was in high school back then. The original SARS came out, right? So SARS coronavirus, at the time, it was just called SARS coronavirus. Now since we have two, we call them SARS coronavirus 1 and 2. So that's what caused the initial SARS disease that started in China, and it only lasted hardly about 2 years, and it went away on its own. So before we could even figure out how to treat it or anything, it went away. And then it came back as a mutated version at the end of 2019. So that's why COVID-19 in the 2019, it's essentially when it came to the world. And it's it's a different virus, but it's a good chunk of it is the same as the original. So the mutations that happened, it made it much more transmissible. So it's more effective in going from person to person, and that's what led to a global pandemic that's still going on, right? So COVID is not over, still going on. It's just that most of us, if not all of us, have some sort of immunity to it. We either got COVID or we got vaccinated or both, right? So pretty much people in general have good immunity, but still going on, right? And then there's a lineage C. This is MERS. This is Middle East Respiratory Syndrome. So this is similar to that. This started in Saudi Arabia, I believe, and still going on, but it's not a pandemic, so it's more regional. So there are also some outbreaks in Korea, so it's not just a Middle East issue. So in South Korea there's been issues, but these are black because these actually kill people, so they're not mild disease. So the original SARS, COVID-19, and MERS, they're all deadly. So not for everyone, right? But people who have risk factors, people who are immunocompromised, people who are older, old age is a big issue, so it kills people. So of course, we are only going to focus on SARS-CoV-2. SARS-CoV-1 doesn't exist anymore, so it's eradicated. Okay, so the spike protein, I'm sure you guys have heard of the spike protein, right? So pretty much all coronaviruses have a spike protein. And when you look at, so this is the virus, right? So you can see on the outside, there is a spike protein, so S. There is an envelope protein that's in the, so it's kind of like a channel. There is a membrane protein that's also inside. And there is a nucleocapsid that essentially guards the RNA inside. So those are proteins that bind to the RNA to stabilize it, right? So when you look at the spike protein, what does it look like to you? Crown, yes. So that's why they're called coronaviruses. I don't know if it's from Spanish or anyone speak Spanish, is it? Corona means crown? Okay, don't rely on my Spanish. So that's essentially why they're called coronaviruses, because they have this spike protein. So the spike protein is the key point. Now I'm going to tell you a few things. Why am I taking time to tell you about this? Because this is the target for vaccines. Knowing this, you're going to understand how the vaccines work. Okay, because anytime the virus comes to the body, the human immune system can make antibodies to different components, right? The spike protein is one target for the immune system, and that's what we're using in vaccines. Now I want to tell you a little more details. So the spike protein actually has like different subunits. So S1 for subunit 1, S2 for subunit 2. And what's unique, and by the way, the spike protein is needed to bind to the host cell, right? So what does it bind to in the humans? It binds to ACE2 receptors. So you probably know from cardiology, the ACE receptors. It actually binds to the ACE receptors in the humans. Now, this is essentially the conformation of the spike protein. When it binds to the so before it binds and fuses to the host cell, that's what it looks like. After it binds, the conformation changes. Okay, so essentially it's gonna look like this. So before fusion, it looks different. After fusion, it looks different. Okay, I'm emphasizing this because if you're the immune system, before it has bound, it looks like something, and so if you're making antibodies to the prefusion formation. And those antibodies are, looking for these spike proteins to bind to. After it binds to the ACE2 receptor, because it changes conformation, those antibodies can no longer bind to it. Okay, so if you are designing, so think about it. If the virus comes to the body and it wants to very quickly bind to the ACE2, your immune system has very limited window of time to make antibodies to the pre-fusion form, okay? And also keep that in mind when you think about the vaccine design. So if you're designing a vaccine, would you rather have a vaccine that's in pre-fusion form or post-fusion? Pre-fusion, right? Because if you make it to post-fusion, it has already bound to the ACE2 receptor. The antibodies cannot bind to it. So you want antibodies ready to go to the pre-fusion, so as soon as the virus comes in, antibodies attack it before it has a chance to bind to ACE2 in it. We'll come back to that. Don't worry if it sounds a little confusing, because we'll finish with the vaccines today. Okay, so here's the life cycle. So here's the coronavirus, right? It comes to bind to the ACE2, so this is the ACE2 receptor on the host cell. It will bind to it. It also needs another co-receptor that helps with the fusion. There are a couple of ways to come into the cell. One is through endosomes. Another is just to fuse into the cell. Regardless, it will come inside and release the RNA into the cell. And then once the genomic material is in the cell, it's a positive sense. So it can just find a ribosome and start translating into proteins that are the products. And then a couple of these, some of these proteins are proteases, right? Because if you're going to have a polyprotein, you're going to cleave them into individual proteins in order to do their function. So one is important because it's a target for our drugs that we'll come back to. So MPro, so pro for protease. M, what does M stand for? It's the main protease. I don't know how they come up with this name. So MPro is a target for one of our antivirals that we'll come back to. But essentially, you're going to process all these, and then some of these proteins have a role for having polymerase. So polymerase will start making multiple copies of the RNA. And then, by the way, because this is an RNA virus, it will never go into the nucleus, okay? So nothing involved with integrating into the host DNA. And then once it's done, it will come out of the cell, and you have new viruses released, and then it can go and infect other cells or other people, right? By the way, if you have any questions on any, just pause me, okay? Otherwise, I'm just going to go a little faster. Okay, so these are the two polyproteins that come out of it. So some of it is cleaved by host proteases. M protease is very important because it will cleave all these other ones that have important role. So MPro has a very important role in the life cycle of the virus. Now, here's what the immune system will see, right? So these are all the different proteins that come as part of the virus, right? So antibodies. Now, antibodies in general, you can think of two types of antibodies, generally speaking, right? One is like binding antibodies. What they mean is that it will bind to the virus. It may mean nothing. It just binds to it. The second is neutralizing antibody. So neutralizing is like not only did it bind, but also neutralize it. And that's really what's important. So when we design vaccines, we're not necessarily interested in binding antibodies. You want neutralizing antibodies, right? And when you measure somebody's immune response to the virus, we look for neutralizing antibodies rather than antibody. So antibodies are one side. The other part is CD4 cells, okay? CD4 cells and CD8 cells, these are very important. In general, when it comes to antibodies, when you develop memory, it may not last a lifetime, right? So as time goes on, it wears off. That's why sometimes you need to get a booster shot, right? Whereas T cells, we think it lasts for a lifetime. So T cells are much more important. And that's why people who are immunocompromised, who may not have good T cell activity, those are patients that are at higher risk and may not necessarily have immune memory to these for a long time. Now, to make things complicated, so the virus changes a lot, right? So there are a lot of variants. So the one that came out of China initially in 2019 changed very quickly. And then you can see that a bunch of different ones started to emerge. Today, so Omicron that started in November 2021 is still what's circulating today. So it's still Omicron, but within Omicron, there's like a bunch of variations. And these are essentially based on primarily on the spike protein. So you know all these proteins that I showed you in the spike protein. So mutations in different regions of the spike protein has caused like different variants. And pretty much all of them are extinct except Omicron. And within Omicron, I just took this screenshot from the CDC because every week these numbers are moving quickly. These are all Omicron, okay? But there are like different lineages of Omicron. So you can see that today KP.311 is what's most predominant. Why am I showing you this? Because when you deal with vaccines, every year they need to decide, kind of like the flu shot when they have to update it every year. That's what we're doing with the COVID vaccines now. So annually they're updating it, and it's based on what's predominant. And I'll show you what's in the vaccines towards the end. And you can, if you click on the COVID data tracker, you can go to the CDC website and look at these numbers. Okay, so this was all introduction. There are 5 guidelines from IDSA. So part 1, 2, 3, 4, 5. What we will mostly focus on is the treatment. So they release, and these get updated frequently, okay? So they have a guideline for treatment. There is one for prevention, one for molecular testing. So molecular testing is essentially PCR testing. Serologic testing is essentially testing for antibodies, which is not for diagnosis. Antibodies is essentially to see if somebody has immunity. It becomes important in immunocompromised patients to see if they have immunity or not. And antigen testing, which you guys have probably experienced, right? So it's those home tests that you take. Those are essentially antigens. There are a couple of exceptions. There are a couple of PCR tests that you can do at home. I'm not going to, in general, we don't have time to talk about tests. So I'm not going to show you all the antigen tests and PCR tests. But these are the guidelines from IDSA. So the first learning objective is the PK/PD of agents used for COVID-19. And I'm going to focus on antivirals, okay? Because you will see that for treatment of COVID, we have antiviral agents. Obviously, this is a viral infection, so we have antivirals. But also, you will see that once I show you the pathophysiology, is that mostly people die not from the virus. It's from the immune system getting out of control. So by the time people are very sick, the virus is no longer there. It's the immune system that's overactive. So some of the agents we will use for those patients have nothing to do with antiviral activity, so things like corticosteroids, right? You guys have already. So I'm not going to cover like what's the mechanism of action of corticosteroids. We're going to talk about tocilizumab, interleukin-6 receptor antagonist, and I thought there was another one, baricitinib, which is a JAK inhibitor. Okay, so the first one, Paxlovid. This is the most commonly used, right? So there are 2 drugs here, nirmatrelvir and ritonavir, okay? Now, normally you would have seen ritonavir when we talk about hepatitis C, but that drug is discontinued, so I didn't get to talk to you about ritonavir this year. But ritonavir, which I'll talk about in a minute, has nothing to do with SARS-CoV-2. It has no activity, and I'll tell you why it's there. But let's focus on nirmatrelvir, okay? So this is essentially the protease inhibitor, and this inhibits that M-pro protein. So the main protease, that's the target for nirmatrelvir. Now, it is metabolized by CYP3A4, and in fact, here's a tip for board exams, right? Anytime you have a protease inhibitor and you can't remember if it's a CYP, is a substrate for CYP or not, it probably is, right? In general, if you have to guess, assume all protease inhibitors are a substrate for 3A4, right? There are always exceptions, but if you're in a situation you have to guess on a test question, just remember that. The half-life is about 6 hours when you use it with ritonavir. I don't know what the half-life is without ritonavir. It's probably under an hour, okay? Now, but half of it is excreted into the urine, okay? So remember that because of renal dosing. Now, ritonavir is actually an HIV protease inhibitor. We're not treating HIV, but here's what's going on. It turns out ritonavir is such a potent inhibitor of CYP3A4 that if you use it with nirmatrelvir, you get to actually make nirmatrelvir clinically useful because the half-life is so short that by using ritonavir, we call this a pharmacokinetic booster. So we intentionally inhibit the metabolism of nirmatrelvir just so we can have enough of it left around for it to work. And even then, the half-life, we only improved it to 6 hours, okay? Now, you know what that means? You're going to have to deal with a lot of drug interactions. Anytime you have a situation like this where you have a PK booster, it's a nightmare for the pharmacist because now everybody's going to come to you like, oh my God, we have ritonavir. Can I use this? Can I use that? Because you've got to check for drug interaction. So keep that in mind. And then the packaging. So they all come into one package. They're co-packaged, so they're not in the same pill. So ritonavir is a separate pill, and nirmatrelvir in a separate pill, right? So you know, people have to take them at the same time. So what you don't want is someone not to take ritonavir and only take the nirmatrelvir as a way to avoid drug interaction. That's not the way to do it because then nirmatrelvir will not work. Okay, so it's co-packaged and they're about. Actually, I'm going to show you the pictures. You can take it with or without food. And again, the mechanism is the nirmatrelvir blocks that protease activity. Here's what the package looks like. And so you have 3 pills. Okay, 2 of them are nirmatrelvir. So it comes in blister package. So you can, you know, so it's easy to do, right? So you take 2 tablets, 150 milligram each of nirmatrelvir, and you take 100 milligram of ritonavir. So 3 tablets, and you have to take it twice a day. So even though we're using pharmacokinetic booster, nirmatrelvir still had to be in, because if you put it all in one pill, it's a giant pill that people cannot swallow, and you still have to take it twice a day. So imagine if you didn't have ritonavir, you would have to take probably 8 pills 4 times a day. So who wants to do that, right? Okay, so that's nice. Now, for renal dosing, if somebody's GFR is 30 to 59, you essentially cut the dose in half of nirmatrelvir. Ritonavir is unaffected, okay? So, but this is nice to do, right? Because they actually have a separate package. So people who need to dose adjust, they just take a different package, and it's still dosed twice a day, you know, but half the dose, which makes sense, right? Half of it is renally cleared. And if their GFR is less than 30, it's contraindicated. Don't use it. Oh, I had it on the slide. Oh, I need to bring the screen down. There you go. Yes?
Does the same concept of starting it within the first 48 hours apply to COVID as well for antivirals?
We'll come back to that. There is a time window. You need to start it within a time window, but it's not 48 hours. We'll come back to that. But excellent question. Yes?
So you said the half-life was without or with the 6 hours?
Oh, if you use ritonavir, it's 6 hours.
Okay.
I don't know what it is without ritonavir. I wouldn't be surprised if it's under 1 hour. They're not going to put that in the package insert. So. Okay, these are all the drug interactions. Okay, so a bunch of stuff is contraindicated because obviously all of these drugs, well, actually most of these drugs, the level will go up. Occasionally you have something that needs to be, you know, it goes the other way around. And then some that are not contraindicated, but you can manage the drug interaction, right? So warfarin is the easiest one, right? You always check INR. And I mean, I'm not sure if how many people are using warfarin anymore. But you know, yeah, so you can dose adjust, and there is a tool. You can go to the drug interaction checker, so for guidance. So this is from the University of Liverpool. They have a nice, they actually have an app you can download on your phone. They have beautiful charts. We'll talk more about that when we talk about drug interactions in HIV, but they also have one for COVID. Okay, don't worry too much about these. I will probably, well, yeah, don't worry, because this learning object is mostly like about, you know, PK/PD. It's not necessarily drug-drug interaction. So you don't have to worry about drug-drug interaction management here. Okay, next drug, molnupiravir. I introduced to you You guys have heard of Yolner? Or I don't know how to properly pronounce this. How do you say it? Yolner? That's where they got the name from. They made some changes like, well, let's make it sound like it's a drug. So they changed this to molnupiravir. But anyway, which I think is offensive to Thor, and I'll explain once we talk about the efficacy of this drug. I'll explain to you why Thor would be offended that this was done. But essentially, this is molnupiravir essentially can incorporate itself into the RNA as the virus is getting replicated, and obviously you don't want molnupiravir in the RNA, right? Because it's going to cause termination of the chain, and that's how it works. Okay, about 3% of it is renal clearance, so you don't have to worry about renal adjustment. Half-life is 3 hours. What does that mean? You're going to take this twice a day, okay? And it does have a high barrier to resistance, and it has also caused some problems, because if you can incorporate into RNA of SARS-CoV-2, can it integrate into RNA of humans? Right? So we're going to talk about some problems with this. Here's the package insert. This is the first time I'm going to introduce to you to EUA. Have you guys heard of EUA, Emergency Use Authorization, which we had a lot during COVID, okay? So when a drug comes to the market, it has FDA approval, right? So FDA approves a drug for an indication or a few indications, right? You as a pharmacist, you always look at the package insert, right? Physicians may sometimes use drugs off-label, and that's okay. As a pharmacist, you can verify drugs that are used off-label. You can always use your clinical judgment. If you think someone is misusing a drug, you can choose to reject that prescription, right? You know, now if you have a discussion and somebody wants to use something off-label, by all means, right? You cannot do that with EUA. When you have emergency use authorization, it has to be exactly what they say in the package insert. There is no such thing as off-label use. So remember that as a pharmacist. So when a drug is emergency use authorization and somebody says, ooh, I'm going to use this for the flu, off-label, you're going to say, nope, reject. Okay? So that's emergency use authorization. So when there is an emergency like COVID, you know, pretty much everything that came to the market was initially EUA, and then in time, you know, they get FDA approval. So Paxlovid, for example, was initially EUA. It is FDA approved now, but not with molnupiravir. So it's EUA, and they will tell you that. What did I highlight here? Yeah, EUA that I talked about, and it's specifically for use for the treatment of COVID-19, not other indications, okay? So anyway, I just want to show you the concept of EUA, because you're not going to get a lot of chances to see them other than COVID. I'm not aware of, pretty much everything you learn in pharmacy school, I'm pretty sure is FDA approved. I can only think of COVID that had EUA drugs, okay? So this one is 800 milligram. It's not a blister package. It comes in a bottle, but the bottle, so it has 40 capsules in one bottle. So one bottle is one course. You give it to the person, you know, which essentially means that because these are 200 milligram, you have to take 4 of them 2 times a day for 5 days. So 8 times 5, 40, right? So you use the whole, so imagine 40 capsules for 5 days. That's a handful of capsules, okay? Let's see what else I had here. You can take it with or without food, and that's all you need to know here. Now, here are the problems. So you cannot use it in someone who's pregnant or is planning to get pregnant because of those mutations, right? So it can affect the fetus. So that's an important patient counseling. So if somebody is to take molnupiravir and is in a you know, childbearing age, you want to talk about the importance of you know, contraception. And for men, it can actually, so at least 3 months after the dose. So they need to use contraception because it can actually stay around in the sperm. So it's not that men are off the hook. Okay, so that's also important. There's also a phone number you can share with them. Now, the third antiviral, these are all antiviral, right? Remdesivir. So remdesivir, which is an injection. So the first two were oral. This one is an injection, okay? Now, this one is also kind of, inhibits the RNA replication. The half-life is 1 hour. What does that mean? No, this one is different because it has an active metabolite that has 27-hour half-life, so that's why it's okay to give this one 1 hour. Sure, the parent drug will go out, in a few hours, half-life 1 hour, but the metabolite helps. So it's only dosed once a day, and some adverse effects, nausea and ALT and AST increase. I personally did some publication on this. We searched the literature because people didn't want to use it in hepatotoxicity, and we essentially found that the current evidence suggests that elevated liver enzymes in hospitalized COVID patients are more likely to be due to the infection than remdesivir. So a 5-day course seems to be pretty safe because COVID can also cause hepatotoxicity. So when they studied in people with COVID and like, oh look, AST, ALT went up, it could be due to the drug or due to the infection. So this is more likely to be due to the infection. What question do you guys have? Those are the 3 antivirals. We're good? Okay, so the second one is now let's talk about pathophysiology and clinical presentation. So obviously this is an airborne, whether it's droplets or aerosols, but essentially you have to breathe it in. Okay, it is not fomite. They put a question mark here. Fomite is essentially an inanimate object. So if I sneezed in my hand and I touched the door, and then later somebody touched the door, that's a fomite, right? So to date, they have studied this. It doesn't look like, because I remember when COVID first started, right? When we didn't have treatment, we didn't have vaccines, anything, like people would go grocery shopping and wipe all their grocery bags and everything, right? It turns out that was all unnecessary because it doesn't look like fomite has a role, but it is, so if you're close to someone who's sick, and it's also time sensitive, like it's not like if I hugged you and you have COVID, I will immediately get COVID, but it takes some time. But that's where all the physical distancing, social distancing, masking, and those things actually do help. At the end, if I forget, remind me to talk about anti-vaxxers, anti-maskers, and anti-paxers. Those are the, okay, don't let me forget. Anti-vaxxers, anti-maskers, and anti-paxers. Anti-paxers is anti-Paxlovid, okay? Okay, so here's the course, right? So let's focus on the top one. So if somebody gets COVID, everybody reacts differently to this virus, and that's why it has caused like a wide spectrum of clinical presentation, right? So you could be in the top, right? So that's about 20% of people. Obviously, if you got the virus, there is some time before you actually develop symptoms, right? So this is pre-symptomatic first. Initially, the incubation time was around 5 to 7 days. With Omicron, it's somewhere around 3 days. Okay, so 3 to 5 days perhaps, right? So if you actually get SARS-CoV-2, you're not going to have symptoms, at least for another 2 to 3 days. Okay. Now, some people will never develop symptoms, and that's about 20% of people. We'll call it asymptomatic infection. So normally you wouldn't catch these people because if they don't have symptoms, why would you test them? And the reason we know this is like, if you are in you work in a hospital and they were actually screening everybody, that's how they found all these numbers. It's like we screened everybody, whether you had symptom or not. We found that, 20% of people actually had it and they didn't have any symptoms, okay? So these are like rough estimates. The second is like some people, and that's about 64%. So most people, right, will develop a mild respiratory symptom. So mild, it means like, it's like a cold, right? Or so you had a fever, you had some respiratory symptoms, and you rested, and then you're fine. You didn't go to the hospital, you don't have to go to the doctor, you don't have to get any treatment. You rested, perhaps you isolated at home so you don't infect other people, and then you went back, you had resolution, right? The third line is about 12% of people, right? So they actually developed, after their mild symptoms, they actually develop hypoxia, so now you need oxygen. These are people who could actually develop severe disease, so they need to go to the hospital, get some oxygen, and that's fine, right? So they just got some oxygen, they got some fluid, some treatment, and they resolve. And then about 4% of people, and these are in percentage, when you do the actual number of people, there are like a lot of people that end up in the hospital. Not only did they need oxygen, but they ended up needing to go to the ICU, perhaps mechanical ventilation, and a good portion of them died. So that's the more critical illness, okay? So there's such a wide variety of clinical presentation. So some of the primary symptoms, I'm pretty sure probably most of you had COVID, so you probably know. I had COVID 2 times. So headache, congestion, runny nose, fatigue, muscle ache, shortness of breath, occasionally nausea, vomiting. This may not happen in everyone, but the virus can actually affect the GI tract, so some people may get diarrhea. Then extrapulmonary, in some people may actually have more neurological consequences, so dizziness, and then dermatologic, so things may happen to the skin. Cardiac issues, including myocarditis, have happened from COVID, so essentially it can affect the entire body. Endocrine system may be affected. I talked about the GI. Some people had, in severe cases, AKI, potentially, organ failure, including hepatic failure. So you remember I mentioned ALT, AST can go up. And thromboembolism, okay? So it's an inflammatory disease. So anytime you have inflammatory disease, it can trigger, DVT. It can trigger stroke. Did they have stroke here? They did not, but it can definitely cause stroke. Ischemic stroke, so these are people who already, if you already had a plaque, it can trigger plaque rupture and thrombosis. And then we have the issue of long COVID. So I'm sure you guys have heard of long COVID, right? So everything I talked about is acute, right? So you get the virus, you're acutely sick, and then you recover. The question is, are you fine 3 months later? And it turns out that one thing that's unique to COVID is that a good chunk of people will not be okay after 3 months. And there's been different terminology that's come around. So we were using PASC initially, so fancy terminology, right? Post-acute sequelae of COVID, okay? Or PCC, they were like, PASC is a handful. Why don't we call it PCC? Post-COVID conditions, okay? This paper came out this year, and they said, what are you doing? Just call it long COVID and get on with it. It's easier to talk to patients. You want to tell patient PCC, or you want to say long COVID? Do you want to tell patients you have PASC, or do you want to say you have long COVID? So they're saying just call it long COVID and move on. What you call it doesn't help with treatment. So that first line is what you want to know. Long COVID is an infection-associated chronic condition that occurs after SARS-CoV-2 infection and is present for at least 3 months as a continuous relapsing and remitting or progressive disease state that affects one or more organ systems, okay? Most commonly, people talk about brain fog, you may have heard, right? So, if you feel like you had COVID and then, 6 months later, you cannot focus, you cannot, you're not doing well on your tests anymore, those are things that could be due to COVID. And essentially, here's the pathophysiology. So these are some common symptoms of long COVID. It can pretty much affect anything. Anything you can think of could be classified under long COVID. but essentially, several things that happen. So blood clots can happen anywhere in the body, right? Which can cause issues wherever those clots end up. And I talked about cognitive impairment that people talk about, brain fog. People can have oxygenation issues. So athletes who have long COVID, they may no longer be able to run as much as they did, right? I don't know any athletes that, I don't know any famous athletes that this may have affected. You guys may know. But essentially, that can affect that. Let's see what else we had here. But yeah, pretty much anything in the body can become part of the COVID, long COVID, okay? And here's the crazy part. So if somebody is exposed to the virus, they may not necessarily develop infection, right? So that's good. But if they do develop an infection, they may be asymptomatic or develop a mild COVID. For asymptomatic people, obviously they will resolve it, but they can develop long COVID. So they're not necessarily off the hook. Okay, so asymptomatic infection can result in long COVID. Now, for people who have mild COVID, obviously a good portion of them will resolve. They rest and they recover. They're not off the hook. They can still, 3 months later, develop long COVID. Or they can actually, instead of resolution, they can go to severe COVID, which, again, they can resolve or develop long COVID. But they can also develop critical illness, end up in the ICU, which from the ICU, they could resolve, or they could develop long COVID, or they could die. So that's essentially the natural course of SARS-CoV-2. That's why, you have a huge spectrum. So, most people are not afraid of SARS-CoV-2 because most people will be, resolving. But also, long COVID does scare me. So, and it doesn't matter. So I personally had COVID 2 times, and I don't think I have long COVID. Other people might disagree, but that doesn't mean that I will never get long COVID. The next time I get COVID, I could very well develop long COVID. So it's kind of unpredictable. Okay, now let's look at here on the x-axis, we're looking at time, right? So time from exposure. So this is at the time that the symptoms develop, so it's -5, so it's from exposure, right? So this is essentially pre-symptomatic phase. So initially, the virus will go up, and then your body will clear the virus, right? And then if you had mild infection, as the virus is clearing, and you recover, right? Now, by the time people have severe, the virus has been cleared, and that's why I say this is mostly due to the immune system getting out of control, right? So most people will be fine, right? My immune system, I'm relatively young. But if I get this in my 70s, I may not be okay, right? Because my immune system is not the same as it is. So immune system can actually get out of control and do some harm. I want to talk about ARDS, and this is just FYI, you guys don't need to know this. So have you guys heard of ARDS? Acute respiratory distress syndrome. Some people call it ARDS if you want, ARDS. So essentially, this is, they look at the PF ratio, so you can classify this into mild, moderate, or severe. So this is how bad the respiratory failure is. So PF ratio, so this is pressure of arterial O2 to FiO2. So FiO2 is a fraction of inspiratory oxygen. And essentially, they measure it, and the lower it is, the more bad it is, okay? I'm just showing you this because the treatments will tell you, if the patient has ARDS, this is the recommendation. So I just want you to see the definition of ARDS. And here's what's going on. So this is in the alveolus in the lungs, okay? So this is on the left-hand side, you're looking at the normal pathophysiology. Obviously, normally, the function here is a clear exchange of oxygen and CO2, right? So hopefully, this is blood. This is into lungs, right? So hopefully, oxygen will come into the blood, and CO2 will go out of the blood, right? So you want that healthy exchange. What happens in severe COVID is that 3 things will happen, right? You're gonna, but first of all, look at all these activated immune response, right? You have a bunch of cytokines. So people call this cytokine storm. because so many pathways are activated at the same time. They call it the cytokine storm. And this is in severe cases, right? It doesn't happen in all of us. So if you have a mild infection, this is not going on, okay? So you have all these activations. So three things will result. You're going to have fibrosis. That's not good. You're going to have fibrotic tissue in your lungs. The second thing is these cytokines will make this leaky, so fluids will start to leak out of blood and go into the lungs. So the more fluids are in the lungs, is it easier or more difficult to exchange oxygen? Difficult, right? You do not want fluids there. And the third one is thrombosis. So this is a capillary. So if you have blood clots, that means doesn't matter if this exchange is happening or not, the blood is not going to move because it's got stuck here, and then you're going to have necrosis and a lot of bad things, okay? So this is just another view, and so I like this picture because it's showing you all this fluid. So it's like you're drowning in your own, it's kind of like you're drowning in fluids in your lungs, right? But anyway, this is the British spelling of edema. They put an O at the beginning. Okay, and then we have, so because that happens, it doesn't matter if I'm giving you oxygen. It doesn't matter if you're on mechanical ventilation. If it's filled with fluids, oxygen is not going to exchange, right? So this is essentially ECMO, okay? So ECMO is forget the lungs. We're just kind of like dialysis for the lungs, okay? So they're going to say, okay, blood will come out of your body, will go into this machine. This machine will exchange the gases for you and then put the blood back in your body. So it's like a machine breathing for you, not necessarily a ventilator, because all the ventilator can do is push oxygen into your lungs, right? So if your lung is filled with fluids, that's not going to do anything. So that's like the worst case scenario, ECMO. Okay, so to recap, this is the big picture you need to know, okay? So from the time somebody gets an infection, and as time goes on and they progress, this is what happens with the virus. So there's a lot of virus replicating, and as time goes on, the body gets rid of it. And then, as time goes on and you develop more severe disease, the immune system will have more activation, okay? And I want you to think of it, it's easier to remember week 1, week 2, week 3, okay? So when someone got COVID, week 1 is when you have mild disease, okay? So if people say, oh yeah, I got COVID, I'm fine, I'm resting, I'm fine. You want to check on them on week 2, because if you didn't hear from your friend on week 2, they're either fine, they're probably fine, but they could have developed more severe, okay? So I usually check on, like my cousin, she's in her 20s, so she's fine, but she told me she got COVID, and then I checked on her on week 2, right? She was fine. And then again, you want to check, so week 3 is when people end up in the ICU, right? So if somebody told you by the end of week 1 they're fine and you never heard from them, you just don't know. So you need to tell people if by the end of 3 weeks you were fine, then you were truly fine. Like you have nothing to worry about. Okay, and not to cause panic in people, but this is the reality of COVID. Okay, let's see what else. Now the other thing that is important here is that if you're treating early, do you want antiviral agents or immunomodulators? Antivirals, right? In fact, if you use immunomodulator, why is it that the viral load is going down during first week? It's your immune system, right? So if you use things like corticosteroids week 1, you're actually doing a bad thing because the immune system is supposed to handle the virus. So if you're giving steroids, and I'm emphasizing this because I'm going to show you that the first treatment that came for COVID was dexamethasone, and people rushed, by people, I'm not even a physician, and PAs and nurse practitioners, whatnot, they rush to give prescription to people in the community, right? Like you get COVID, go ahead, and that's a bad thing. You do not want to do that initially because you can actually increase the risk of dying. Now, as people end up in the ICU, do you need antivirals? No, right? What are you doing with the antivirals? Now you need immunomodulators, okay? And then you have this phase in between that you may need to overlap antivirals and immunomodulators, okay? So this is the big picture. What question do you guys have? I'm going to talk about recommendations for treatment in a second, but first I'm going to show you risk factors for progression. So obviously not everyone will progress to severe COVID-19. So here are the risk factors, okay? First and foremost, study after study shows the higher the age, the more likely that people will develop severe disease. So here, so this is the reference point 1, right? So this is like, is this odds ratio or it doesn't say. Let's say this is odds ratio. So 18 to 39 will say unlikely that they will develop, all else equal. So assuming someone is not a transplant recipient or, has, someone doesn't have CKD, all those comorbidities. So a healthy person, 18 to 39, unlikely to progress to severe disease. But then as age goes up above 40, right, you will double the risk. And then, at 50 and higher is like fourfold. And then you get to 85 plus a tenfold, okay? And this is risk ratio I was looking for. It's not odds ratio, it's risk ratio, okay? And then, so that's age alone. So you see, age alone is more of a risk factor than, let's say, obesity. Sure, obesity will increase risk by 30%, but this is like, let's see, if 0.6, this is like, I'm trying to quantify, it's probably 1,000? Is it 1,000% increase? Somebody do the math. I think it's like 1,000 increased risk. This is like 30%. Okay, diabetes, 30% increase, CKD, 20%, COPD is 20%, neurologic disorders, 20%, coronary disease, 10% increase, okay? Okay, so then in this box, so in general, obviously the higher the age, the worse, but we use the cutoff at 50 or higher. You have high risk of severe COVID-19, some chronic diseases. Pregnancy, I'd like to bring your attention to pregnancy because pregnancy alone, so if someone is healthy but they're pregnant, that's a high risk, both for the mother and for the fetus, okay? So I emphasize this because the other issue with pregnancy is that many of these drugs that come to the market initially they're not studied in pregnancy, so people are not sure, if it's safe to give or not. The same with vaccines, right? Initially, vaccines were not studied in pregnancy, but pregnancy alone is not a good combination with COVID. And in general, you can think of people who are pregnant, it's not necessarily immunocompromised, because I've heard people say, well, pregnancy is immunocompromised because the body's immune system has been suppressed, so it would not reject the fetus. That's not necessarily true. It's that immune system has changed a little bit, okay? And we have a bunch of other things. Oh, diabetes, usually uncontrolled diabetes is considered immunosuppression. Somebody who is well managed with diabetes is, it's not really. So also keep that in mind. So let's talk about immunocompromise. So it's good approximately 3% of adults in this country are immunocompromised for one reason or another. Moderately immunocompromised is things like cancer treatment, including for solid tumors, immunosuppressive therapy, but also people who are on dialysis, they're considered moderate immunocompromised. If people have advanced HIV, and we measure that by CD4 count if it's less than 200. And for severe is essentially people who have hematologic malignancies with active treatment. Stem cell transplant, so if they have some other immunosuppressing agents on board, and I see they put HIV on both sides here, but it depends on how long they've had HIV. So let's see. And just to show you the risk of hospitalization and death. So essentially, these are people who have stem cell transplant. The risk of hospitalization and death is several-fold higher than the average person. The same with organ transplant. So you see the risk of death is highest for organ transplant within 5 years. And the reason there's a time component to it is when someone gets a transplant, initially the immunosuppression is a lot more intense. As time goes on, they ease the immunosuppression as the body adjusts to the new organ. That's pretty much it for the risk factors. What question do you guys have? You guys want to take a break before we jump to the outpatient treatment? Okay, let's take a 10-minute break. We'll be back at 10:10.
So much fluid buildup that the patients were getting it. They
That's-
realized.
That's the primary underlying pathophysiology.
I was just curious.
Yeah. Okay, the next learning objective is given a community dwelling patient. Yes. What's that? I cannot hear you. Can you hear me though? Yeah, okay. Given a community dwelling patient with COVID-19, design an appropriate management plan. So I have to stand here because the clicker doesn't have battery. Okay, so this is what the IDSA guideline is recommending for outpatient treatment, okay? Now, not everybody should be treated. Only people who are at high risk of progression to hospitalization, okay? So essentially progression to severe disease that would need, so in other words, when I got COVID, I did not get treatment, okay? So keep that in mind. It's only for people who are at high risk of progression. The preferred treatment is Paxlovid, so nirmatrelvir, ritonavir, initiated within 5 days. So here's the timing, okay? It has to be within 5 days. Past 5 days, they don't qualify. And again, remember, think of week 1, week 2, week 3. Is week 1 that's mostly where you're going to have a lot of the virus replication. So you need these are antivirals. So you need to have it in the first week. Now the exact cutoff for this is 5 days. Second, now these two are preferred. Remdesivir is the second preferred. It has to be initiated within 7 days of symptom onset. Okay, symptom onset, not within when you test positive. Okay, so when people first started to notice symptoms. Okay. Now, what do you notice between 1 and 2? Which one would you prefer? Why do you prefer 1? No, this is not duration of treatment. This is how much time you have to start it. The second one, in fact, duration of treatment for number 1 is for 5 days. The second one, you only treat for 3 days. What do you prefer the second one? Okay, so you have bigger window. What else do you like? Yeah, the problem is an injection. So this is for outpatient management. So how do you? And that's exactly why I don't think anybody has. I don't know anybody who has used remdesivir because you will have to send them to an infusion center. Guess who's usually at the infusion center? Usually cancer patients, right? So these are people who need infusion, right? Highly immunocompromised. Do you want to send a COVID bomb into an infusion center to? So for that reason, I'm not aware of a lot of people using remdesivir, but it's definitely easier regimen as far as you have a bigger window to start it, and it's only for 3 days. Okay. So most people will go with Paxlovid. Now, alternative is molnupiravir. Molnupiravir has also a 5-day window to start, and treatment duration is also 5 days. Okay. Now, the problem is it's less effective than the first two, so that's why it's alternative. Not to mention that you have all those adverse effects. So, it's mutagenic, so you have all those issues with pregnancy or potential pregnancy, right? Number 4 is convalescent plasma. So this is essentially, imagine someone had COVID and they recovered. Their immune system took care of it. So you get their blood, you process it, you get the plasma where it has antibodies, and you inject it into other people. Convalescent plasma had a bigger role when we didn't have this option. I'm not aware of who's using it. And they specifically say if you have no other option, you may get convalescent plasma. So it's not readily available. I mean, I don't know where to go to get convalescent plasma, so it has to be readily available. But also, anytime you have plasma infusion, you have the risk of infusion reaction. So that's also not good. And then last, fluvoxamine. Have you guys heard of fluvoxamine? Psych just started, right? This block B, Psych. Okay, you guys will see fluvoxamine. But anyway, there are some studies that fluvoxamine may work, but there's not enough studies. So they just say if you are to use it, it better be in the setting of you're literally doing a study. Yes?
Is there any other indication for these antivirals besides COVID?
No, those 3 are only COVID. Remdesivir was designed for Ebola. It's not FDA approved for that reason, but that's what it was designed for. The other 2 were designed specifically for COVID.
Are they emergency use authorization or
No.
FDA approved?
These 2 are FDA approved. Molnupiravir is EUA. Convalescent plasma is not a drug. Fluvoxamine is FDA approved for psych reasons that you will see. So you can use it off-label. So that's how. So a few agents, because we don't have a lot of treatment, people started to test a bunch of drugs that are already on the market. So here's what happened. Somebody, and by the way, COVID started, the government put a lot of grants because we have a pandemic. We need researchers to drop whatever they're doing and start researching COVID in order to, so people got a lot of funding to test a lot of things. So they're like, okay, in my lab, I tested fluvoxamine, and look, it has antiviral activity against SARS-CoV-2. Okay, that doesn't necessarily mean that they will work in the body. So you will see, actually, I think it's coming up next. Here you go. A bunch of stuff you should not be using. Hydroxychloroquine or chloroquine with or without azithromycin. This one was the first one they tried. In a lab, it worked in a test tube, right? We give it to people, study after study shows it doesn't work. Lopinavir, ritonavir, it's a protease inhibitor for HIV. They tested in the lab, it works again, it's an antiviral activity against SARS-CoV-2. We give it to people, it didn't work. Inhaled corticosteroids, since there are respiratory symptoms for people, let's give them inhaled corticosteroid. They say don't do it. Famotidine, you guys remember from GI? Somebody tried it in their lab. Oh, antiviral activity against SARS-CoV-2. They tried it, it didn't work. Don't do it. Ivermectin. This is for worms. Worked in the lab, not in people. Colchicine. You guys remember from cardio? Somebody tried it in the lab. Antiviral activity against SARS-CoV-2. It didn't work in here. So anyway, here's a list of things the guideline says do not use. But anyway, fluvoxamine is one that it might actually work because there are some studies that have shown it work. It's just not enough evidence to know for sure. So it's they're saying if you want to try it, Not to mention fluvoxamine is cheap. Those drugs are expensive. You know how much is Paxlovid for 5 days? I don't know, $1,000? I don't know. Yeah, probably. Somebody look on, what is it? Okay, so I was being cheap. It's 50, sure, somewhere, assuming no insurance, right? So if you have good insurance, it should cover it. The same, remdesivir, these are all, there is no generic. They literally came to the market in the last 3 or 4 years, so they are only brand. They're expensive. But anyway, my point is fluvoxamine is cheap, it's generic. So, somebody cannot afford this. It may not be the bad idea to say, how about you use fluvoxamine off label? Okay, so let's do some patient cases. We'll do things a little differently, so because we have to go a little faster. So I have 3 patients for you. MF is 87-year-old. Can you guys believe that? So patient 1 and 2, they're in the outpatient setting, okay? So they all have the same or similar chief complaints. So they all have fevers, right? So this patient is already admitted to the hospital, okay? But let's focus on the first 2 patients. So fever, either a dry cough or sore throat. MF has type 2 diabetes. JO does not have any past medical history, so she is young and healthy. They both have received some vaccines. So this patient got 3 doses of ancestral mRNA, ancestral meaning the first version that came to the market. That patient got Spikevax. This patient got Comirnaty. Spikevax is essentially Moderna's vaccine. This is Pfizer vaccine. And this patient has SpO2 90% on room air. This one is 96% on room air. They all tested positive for SARS-CoV-2. Now, this is the time to talk to your team. What do you recommend for this patient? No COVID treatment needed, treatment outpatient with oral treatment, or sent to ED for IV treatment but not hospitalization, or sent to ED for hospitalization consideration. Okay, you guys have your response cards ready?
Welcome back, guys.
Okay, 1, 2, 3. Okay, thank you. And that's okay. I didn't talk about it, but the correct answer is D. Just because I didn't talk about it, SpO2 is 90% and it's going down. And this is an 87-year-old. SpO2 is, less than 94%. I'm really concerned that this patient might is going down. Okay, so it's best to send this patient to the hospital, to the ED for hospitalization consideration. Okay, but sure, regardless, you do want to give them treatment. Okay, so let's do number 2. So what do you want to give this patient? A, dexamethasone. B, remdesivir. C, Paxlovid. D, lopinavir. E, molnupiravir. F, hydroxychloroquine. Or G, no treatment. So I know you guys don't want to do no treatment. So for F, if you think it's F, just raise your hand. Okay, ready? It has not been 5 days yet. Let's say symptoms started 2 days ago. Okay, 1, 2, 3. We'll go to team 5. Why do you want to start Paxlovid?
It's preferred and it's been less than 5 days since symptoms onset.
Okay, excellent. Team 2, you guys say remdesivir.
It's an injection. He's in the hospital. He doesn't have to take anything orally, and it's also preferred.
Okay. Can we not do nirmatrelvir, ritonavir in the hospital?
We can't.
You can, but why would you want to give a patient like 8,000 tablets?
Okay. So uh, remdesivir and nirmatrelvir are obviously both first line. This patient qualifies for both of them, right? So it's a matter of getting a little more information, right? So I said this is an outpatient, right? So we said in the previous question we would like to send them to the ED. The question is, should we give this patient something before they go to the ED in the meantime? Like, do you trust that this patient will go to the ED, but if they decide then not to go to the ED? If that's the case, you know, and obviously, if you are in a position to give them packs, because I don't know if you're in the ambulatory care setting, you know, if you're at the retail pharmacy, you may not necessarily be able to do it, right? Although some retail pharmacies may be set up to actually give Paxlovid to people. If you are already in the ED, then I would prefer remdesivir, right? Because you're in the ED, give IV, and if things go south, you don't want oral medication, right? So technically, both answers are correct, but you know, depends on where you are. If you haven't made it to the ED, you have no choice but to do Paxlovid. If you are in the ED, I would prefer remdesivir. What question do you guys have? That sounds good. Okay, so what about patient 2? So the second patient, the young, would you say no COVID treatment, outpatient with oral, sent to the ED for IV, or sent to ED for hospitalization? Remember, one person from each team log your answers in a Word document so we can upload on Canvas at the end. So simple Word document, just the names of people who are here at the top, and then you just put 1, whatever, A, B, or C, 2. That's all you need to do. Just document the answer.
Yeah. We didn't really have all the information.
Maybe don't ask. But isn't then she's higher risk if she's because it's her and the baby. For
Okay, ready? So number 3, 1, 2, 3. Team 4, why do you not want to treat this patient? Okay, so you don't think this patient needs hospitalization? No, why not? Okay, so SpO2 seems to be pretty good, right, on room air. Doesn't need oxygen, right? So, and young and healthy, so no need for hospitalization. Yeah, let's go to question 4. The only thing changed for patient 2 is like, what if she is pregnant? Everything else is the same. Yes. Yes, yes. The previous was A. Yeah, number 3 was no COVID treatment needed because she didn't have risk factors for progression. So now number 4 is she is pregnant. And again, let's say symptoms started 2 days ago.
Yeah, but it's also like, I guess it's like there's nothing that indicates that she does have severe.
Yeah, but she only 2 days ago. If it was like 3 weeks ago, then I'd be like,
Yeah.
Okay, so number 4, 1, 2, 3. So it looks like A and B. Team 7, what do you guys want to treat this patient? Pregnancy risk factor for her or for the fetus? For both, right? Yes, so you do want to treat, so best answer is B. But why not send to the hospital? What's that? Yes, 2 days of symptoms. Okay, treat outpatient, and looks like SpO2 is stable on room air. Doesn't seem that this patient needs oxygenation immediately, right? Excellent. So if we are to treat it, let's see what should be the treatment. So question 5. And again, if you say F, you can raise your hand. Okay, let's see what you got for number 5. 1, 2, 3. Looks like everybody says C, which is the correct answer. You absolutely want to avoid molnupiravir, right? Molnupiravir is contraindicated. Remdesivir, you don't have access in the outpatient, right? Difficult to set it up. And Paxlovid is absolutely the preferred for pregnancy. Okay, so doesn't matter, and I'm telling you this because you will be in a lot of situations when you can educate people to go and get their Paxlovid. If someone is pregnant and young and healthy, it's good for pregnancy and for the fetus. Okay, so that qualifies them to get treatment. What question do you guys have? Okay, so they did a couple of EPIC studies, so EPIC HR and EPIC SR, HR for high risk, SR for standard risk. Essentially, they randomized people to give them, people who have COVID, outpatient, to give them either Paxlovid or placebo. The standard risk found no difference. Okay, standards like young, healthy people, give them placebo versus Paxlovid, it made no difference. But it did make a difference for high risk. So specifically, they looked at adults who were at high risk, so either age 60 plus. So these are the criteria they use for this study. So they use the cutoff of 60, either BMI more than 25, or a bunch of other comorbidities or immunosuppressing things, right? And they wanted to see either reduction in all-cause mortality or hospitalization. Okay, so because it's outpatient, so people may not necessarily die, but it at least prevent you from needing to go to the hospital. And what they found is that, well, first of all, when you look at baseline characteristics, about 2/3 of patients got treatment within 3 days, but everybody had to get treated within 5 days, okay? But 2/3 of them were actually pretty fast, within 3 days of symptoms. And what they found is that Paxlovid, it actually reduced significantly either death or hospitalization. So you can see a risk difference of 5.6% that was statistically significant. Okay, and that's why we recommend it for high-risk patients. And then when they looked at, okay, does it make a difference if it was within 5 days or even sooner? Would you get more benefit? They found no difference. So whether you were starting it within 3 days or 5 days, you got the same amount of benefit. Okay. So as long as it's within 5 days, so on day 4, it's not too late. On day 5, it's not too late, okay? And that's important because by the time you have symptoms, by the time you get an appointment with your doctor, by the time they test, the test results come back, and then you go to the pharmacy, pick this up, that actually can take, quite a few days, right? A lot of doctors are not open on the weekend, so if you got symptoms on Thursday or Friday, and you were trying to get an appointment, it might be some time. In fact, there are some options for test and treat. So some pharmacies participate in where you go get tested, and they give you Paxlovid. And there's a website for that. You can Google it. But essentially, because time is of essence here, within 5 days. And then when they looked at hospitalization. One thing, now I forgot to tell you, so this study was in unvaccinated people, okay? So this was early on when we didn't have vaccine. So in unvaccinated people, it made a difference. So the question is, what about the rest of us? Now we're vaccinated or we had COVID, because when they looked at people, they looked at serology at baseline. They said, oh, look, some people had some immunity, and it looked like the benefit is less, but it was still significant. Okay, so if they had antibody positive, that means somebody had prior exposure to the vaccine. But then they found that people who received monoclonal antibodies, they did not get the benefit. So, because the antibodies was actually preventing death and hospitalization. But anyway, the recommendation is that still we're going to give it because a lot of observational studies have shown that people who are vaccinated, they may still benefit if they are high risk. So that continues to be the recommendation. Now for adverse effects, it looked like adverse effects were higher in placebo, which means that these adverse effects probably due to the infection rather than treatment. So if you treat the infection, of course the adverse effects will go down. So there may not necessarily be adverse effects. So they said, what if we literally look at what we think is due to the drug, so slightly maybe more with nirmatrelvir, but in general well tolerated. Probably the one adverse effects that it's not on this table, but you should tell patient is dysgeusia, right? Dysgeusia is like change in taste. So people usually, a lot of people who take Paxlovid can tell like the difference in taste. So I think it's a metallic taste if I remember correctly. But that's something to let them know because it's unpleasant. Okay, move out. So this is the molnupiravir study out for outpatient. Okay, they also did the move-in for inpatient. So essentially they said, okay, we are also going to look at high-risk patients. We're going to give them molnupiravir or placebo and see if it makes a difference for mortality or hospitalization. And what they found is that, actually let me go back. I don't think I told you the, I didn't put it on the slide, but for Paxlovid, the benefit was about 89% efficacy, okay? I don't have it on the slide, but just keep that in mind. It was pretty high, about 89% efficacy. So I want to compare that to molnupiravir because what they found with molnupiravir is that it does work, but the efficacy was about 30%. Okay, this is like relative. So there's definitely a benefit. This was, again, in unvaccinated patients, okay? So, and that's why it's alternative. So 30% compared to 89 or 90%. 89 or 90% sounds a lot better. So Paxlovid is the preferred, molnupiravir is alternative, okay? And one patient died in molnupiravir versus 9. So looks like it may have mortality benefit. I know, just like before, I show you the studies just to show you the why. You don't necessarily have to remember the studies, but the recommendations for treatment is what you need to know for test. And then lastly, Pine Tree was the study they did for remdesivir. Essentially the same thing for outpatient, right? They said high-risk patients, we're going to randomize you to receive remdesivir. The first dose is a 200 milligram. Day 2 and 3 is 100 milligram, right, versus placebo. The same thing. They want to see the risk of hospitalization or all-cause mortality. And what they found was that it significantly reduced by 87%. So again, remdesivir efficacy much better than molnupiravir, which was 30%. So that's why they have ranked them. Paxlovid number 1, remdesivir number 2, and molnupiravir number 3. The other thing they did here, because this was up to 7 days, what they found is that most people received it within 5 days anyway, and they couldn't find statistical significance on day 6 and 7. And they think that's because they didn't have enough patients there, so they still do recommend, up to 7 days. So have you guys heard of Paxlovid rebound? Some of you have Paxlovid rebound. So here's the question. This patient is very concerned about Paxlovid rebound because you guys wanted to give her Paxlovid, assuming she's pregnant. Okay, she's hesitant to take it. And by the way, I'm bringing this up because what I hear in the community is like a lot of doctors, somebody qualifies for Paxlovid. This is the anti-Paxer. They're like, oh, I don't want you to get Paxlovid rebound, so I'm not going to give you Paxlovid. So imagine I have a kidney transplant and I have COVID, and they're like, I'm not going to give you Paxlovid because I don't want you to get Paxlovid rebound. So you will be in a very good position to provide some Paxlovid rebound education to the anti-Paxers. Who wants to volunteer? Who knows about Paxlovid rebound wants to share some thoughts? Well, first of all, what do you think they refer to by rebound? Okay, so sounds like you're having COVID again, but what exactly again? The symptoms came back again, or the test came back? Yeah. So not that, so yeah, so I had COVID, and my symptoms resolved. Now I got tested. It was negative, right? Then I tested again because I need to go back to work, and I wanted to have one more negative test so they can let me go back to work. And I tested again, and it's positive again. So rebound. Okay, so what's going on? Then I had to stay home more because now my job won't let me to come back because I tested positive again, even though my symptoms are gone. Okay, so so let's talk about that. So you should never say Paxlovid rebound. Anybody who tells you the words Paxlovid rebound, they don't know what they're talking about. It's COVID rebound. It's just not because people who got placebo, they had rebound. Okay? People got placebo, they tested negative, and then a few days later, some of them tested positive. It had nothing to do with Paxlovid. Okay? So that's the education you want to provide, that there is a phenomenon as COVID rebound, has nothing to do with Paxlovid. It can happen with anything, but if you do nothing and stay at home, you could have rebound. It doesn't happen to everyone, right? And it doesn't mean anything. Doesn't mean that you're going to be more infectious or that you're going to have more bad outcomes. It means nothing. So what did I put here? They looked at rebound rates, right? So first of all, fewer than 10% of people may have these rebounds, but most patients will not experience it. So in general, that is not reason to not give people Paxlovid. So rebound is not associated with I kind of mentioned this, but it's on the slide too. It's not associated with increased risk of progression to disease or hospitalization. No evidence to support efficacy of repeating antiviral course, right? So so Paxlovid for 5 days. If someone has rebound, they do not need to do another 5 days. Okay. They may need to restart isolation just because nowadays a lot of jobs don't have isolation requirements, but if in case we're in a situation where your job requires you to isolate and come back when you have a negative test, it may restart the isolation timeline. Okay, so that's all the treatments for outpatients. So in summary, these are the 3 antivirals, right? So remdesivir within 7 days, the other 2 within 5 days, right? With ritonavir, you're going to have drug-drug interactions. So keep that in mind. These 2 are for 5 days. This one is for 3 days. I didn't put the 3 days, but you guys know this is for 3 days. Adverse effects, overall, they're well tolerated. As I mentioned, nirmatrelvir may give you dysgeusia. Let's see, pregnancy, you want to avoid molnupiravir. This is perhaps the most preferred for pregnancy. But if someone is pregnant and hospitalized, you could use remdesivir. No dose adjustment needed for molnupiravir and remdesivir. For renal, you need to dose adjust nirmatrelvir. And that's pretty much it. What question do you guys have before we go inpatient? This was outpatient. Good? Okay, so let's see what's happening. So I focus more on the outpatient because it doesn't matter where you go, you will have to deal with outpatient management of COVID. Even if you end up working as an inpatient pharmacist, people come to the ED and not necessarily get admitted, so you treat those as outpatient or as people get discharged. So I try to control myself and have fewer things for the inpatient because I am an inpatient pharmacist. Okay, but just so we are on the same page with terminology for oxygenation. Okay, this is just FYI because, and the reason I'm showing you this because guideline recommendation is based on oxygenation status of patients. Okay, so when somebody needs oxygen supplementation, what that means is like, you're breathing air is not enough oxygen. How much oxygen in the air? What's your FiO2 right now? You probably learned in middle school or elementary school. 21, right? When do they teach that in science? Is it middle school or before that? When it's in high school? You know, they say like how much of air is oxygen is 21%, right? So anytime you open EPIC chart and you look under, you know, when you look at FiO2 and it says 21%, you know that the person is on room air, right? 21%. And this is, you know, assuming at sea level, like pressure can affect it. Well, that's not complicated. But in general, 21% of air is oxygen. So if 21% oxygen going is not enough, somebody's SpO2 is going down, you need to supplement it with oxygen. So low flow is like, so you know, you give somewhere around 1 to 6 liters per minute. So there is, so initially low flow. Then you have high flow. I'm going to ignore the moderate. So high flow, you know, so you essentially giving a lot more. So about 15 liters per minute, and that can bring your FiO2 to, you know, 60 to 90%. At some point, you know, this is not enough. So you're going to go into, you know, higher pressure. So there is CPAP that you guys, I'm sure you have learned when you learned about respiratory. But then the most is ventilation, right? So ventilation, you're going to go, you know, pretty much 100% FiO2. So essentially 100% of what's going into the lungs is oxygen, okay? So essentially think of a low flow oxygen, high flow oxygen, mechanical ventilation, okay? So it, you know, it transitions into higher intensity of giving oxygen. So here are the guideline recommendation. Now this is the NIH, but IDSA guidelines pretty much is the same thing. I like this table from NIH because it put everything in one table and it's well organized, whereas IDSA goes like statement by statement. You know, I'm not gonna go statement by statement. This is much nicer, okay? So let's go row by row, okay? So this is the most important thing you need to know, okay? This table, nicely summarized. And essentially the first row is, okay, not everybody in the hospital who has COVID is in the hospital because of COVID, okay? So let's say somebody had COVID, got into a car accident, and ended up in the hospital. You know, just remember those, you know, that's still in the category of outpatient. Just because they end up in the hospital for other reasons, you can still manage them. So you go with Paxlovid if they need it, whatnot, right? So when you go to the second row, this is like essentially people who are in the hospital because of COVID. So the first, this second category is people who were sick enough to come to the hospital, but they don't necessarily, they're not on oxygen supplementation rate, okay? So if you had to guess, this typically happens in the first week because they haven't progressed to severe enough to require oxygen. So these are pretty easier to treat. So essentially, they're saying the main stay is to use remdesivir. So you want your antivirals, okay? So we don't do oral antivirals. You know, if someone is hospitalized because of COVID, we're not going to do oral, right? So remdesivir is your option. And they have specifically a recommendation against dexamethasone. So do not give dexamethasone. If someone does not, if someone is not on oxygen yet, that means they haven't, their immune system has not kicked in to cause all those, you know, cytokine storms. So you do not want to give dexamethasone because it will actually prevent the body from clearing the virus. So remdesivir is the way to go. And then of course, you know, people who are acutely ill, for the rest of the course, we didn't talk about this, but essentially anytime somebody is acutely ill and is hospitalized, depending on risk factor, they may need VTE prophylaxis, right? So they have a whole column of recommendation for VTE prophylaxis. So these patients may need, you know, VTE prophylaxis with heparin. Now, we go one row lower. Now, this is the darker orange. These are people who are hospitalized for COVID, and now they need oxygen. And this is essentially your low flow oxygen, so very minimal oxygen. So this is still in the early phases of the disease, so you do need your antiviral. So you have remdesivir at the top. So remdesivir is going to be the mainstay. But because they needed oxygen supplementation, that means you have cytokine storm starting. So you want to give dexamethasone. So you do dexamethasone plus remdesivir combination therapy. Okay. Now for these patients, they are actually found that for VTE, they actually may benefit from therapeutic dose, not just prophylaxis, so higher dose of VTE treatment. Okay. Now, if the next row essentially is if the patient patients who are receiving dexamethasone and who have rapidly increasing oxygen needs, things are going south, right? You started remdesivir and dexamethasone, and they were on low flow oxygen, but they're going to need more and more oxygen. You know things are going south, so you want to start adding either baricitinib or tocilizumab. So these are to manage the cytokine storm. So these are your immunomodulators. So you choose one or the other. You don't do both. Most people will do IV tocilizumab because it's IV, right? These patients could end up in the ICU soon. And then if someone is on high flow oxygen, which is here, essentially you will do dexamethasone, right? And you probably can still do remdesivir because it's, it's kind of ending towards that, where almost the virus is gone, but not, there might be a little bit of the virus left. And you definitely, here with the dexamethasone, you add either tocilizumab or baricitinib. So essentially, the mainstay of treatment here is to target the cytokine storm. And then if somebody has advanced enough to be on mechanical ventilation or ECMO, there is absolutely no need for antiviral anymore. This is like you're towards the end, right? So the virus is pretty much gone. It's your immune system completely out of control. So you don't add remdesivir down here. It's essentially dexamethasone and either baricitinib or tocilizumab for the cytokine storm. Okay, so that's essentially your treatments. Now, one thing is, so the therapeutic dose heparin is only for people who are on low flow oxygen. If they go on high flow oxygen, you go back to VTE prophylaxis. Okay, and why is it that this was prophylactic, then therapeutic, then prophylactic? Because with anticoagulation, you always have to manage bleeding and preventing clots. So what they found is that if you do therapeutic here, there was too much bleeding. So the balance is, the evidence shows that VTE prophylaxis, in this advanced patients, whereas therapeutic dose did benefit these people who they were on low flow oxygen. What question do you guys have? That was a lot. Good? Okay, and then these are the things they say don't do. Corticosteroids, if the patient is not on oxygen supplementation. Okay, that's the first, initial. So if they're in the hospital and if they're not on oxygen and they're trying to start corticosteroids, you go and block it. Okay, you can reject it. Now, if they're already advanced to mechanical ventilation or ECMO, there's no need for remdesivir. Like, what are you doing? There's no virus going on anymore. There's no need for convalescent plasma in the hospital. And anakinra, I think it's an interleukin-1. You guys know? If I remember correctly, I think it's an interleukin-1 receptor antagonist, and that didn't work. So anakinra, you should not use as one of the immunomodulators. And of course, the other things that we had avoided before, still don't do it. Hydroxychloroquine, hydroxychloroquine became a political thing, but studies show don't do it. Lopinavir, famotidine, ivermectin. Ivermectin was also politicized. There's really no benefit to ivermectin and colchicine. Okay, so now let's visit patient 3. So this patient is already in the hospital. She is on high flow oxygen. Okay, past medical history, cirrhosis, and she's 65-year-old. So talk to your team, see what you want to do. If you say F, raise one hand. If you say G, raise two hands. By the way, in the hospital, it doesn't matter when the symptoms started, right? That's only for outpatient. In the hospital, what matters is the level of oxygen supplementation. You guys ready, or do you need another minute? Minute? Okay. This patient has child PUA. Yeah.
For the chart that you gave us, it gives like A high patients, B2 A patients. Do we need to know?
No, don't worry about
Oh
it.
no, don't need to know
This
that.
is just showing you the level of evidence for each.
Okay. Yeah, because I know I was saying add if the certain patient is like a C2A.
Yeah.
Theoretically, we did. We're in double, man.
Okay, let's see what you guys got. Number 7, 1, 2, 3. So looks like between E and F. What did you guys say? F? Okay. We'll go to team 5.
We said F, because the patient is on high flow oxygen and the patient is hospitalized, so we do dexamethasone plus the toci, and we added the remdesivir.
Okay, is it safe to use remdesivir in cirrhosis?
Yes.
I say it is. Right?
To be safe in regards to hepatotoxicity.
Yes. Okay, so you want, so F is the correct answer. You want, you definitely want dexamethasone, and you want tocilizumab, and you want remdesivir. So high flow oxygen, still room for remdesivir. Okay. You should never use tocilizumab without a corticosteroid. So the only time tocilizumab has worked is when combined with a steroid. Okay, so this was the recovery trial that came early during the pandemic. Okay, essentially they said this is hospitalized patients with COVID when we had no treatment for COVID. They randomized and they said, we think the pathophysiology is, cytokine storm. We're going to randomize people to get whatever we're doing for everyone, and randomize people to get dexamethasone. Okay, and what they found is that 28-day mortality was reduced significantly. Now, when I said treatment, so 26%, let's say 26% died in usual care, and 23% died in dexamethasone. So still 23% died. That's terrible. But we just brought it down from 26 to 23. Okay, so it's not a cure by any means. So you do not want to be in this group of people where you're hospitalized with COVID, because a good chunk of them, mortality rate is too high, right? Now, one thing they found here is that, look at this one. People who did not need oxygen, this point estimate is on the right-hand side where it benefits the usual care. That means people who got dexamethasone, numerically 19% more people died if they got dexamethasone, right? But sure, I mean, it's not statistically significant, but if you were in this study and you were not on oxygen, would you want to be in this group or this group? Because this point estimate is on the right-hand side, right? And this was a smaller group, so about 1,500 people were not on oxygen, whereas the rest of them, so how many is that? It's probably 5,000 or 6,000 people. But anyway, that's why we're saying do not give dexamethasone. Even if somebody is hospitalized, if they're not on oxygen, you do not want to use dexamethasone or any steroids, because that could backfire. Yeah, that's what I have in that box. So in those with symptom duration of less than 7 days, there was a 1.6% numerically higher rate of death in dexamethasone group. Now, we published with the residents. I work with our residents. I don't know, you guys know Dr. Stephanie Jin? You might have her. She was a resident at the time when we wrote this, but she is the emergency medicine pharmacist now here at the medical center. But anyway, we wrote a whole paper on the harm of using steroids in the wrong patients. Okay, and this was, I actually started this mostly because I have told you guys my wife works at CVS, so she was getting all these prescriptions coming for dexamethasone because doctors found out that dexamethasone reduces mortality. So people in the outpatient, it has no role in the outpatient setting. Okay, so we put this there, and these were, so I told you why it shouldn't be used early during COVID, right? Because the virus is replicating and you need the immune system to take care of it. But also there are adverse effects due to steroids, right? So you guys know from your other classes, long-term adverse effects of people who are chronically on steroids. You can have hyperglycemia. It's an immunosuppressive drug, so it increases risk of infection, gastric ulcer, osteoporosis, VTE, psychosis. But sure, we're not using it long-term. We're using it just for a few days for acutely. So in the acute phase, it's not well understood. In fact, it probably doesn't cause GI bleeding. But one thing we know for sure, hyperglycemia, even for a few days of steroids, does cause hyperglycemia, which can lead to bad outcomes in people who have diabetes and are acutely ill. Now, for remdesivir, they did a systematic review and individual patient data meta-analysis to see if there is a benefit to in regards to mortality. Because if it's just reducing the replication of the virus, does it lead to mortality benefit? And they found that here, statistically significant, that it does reduce all-cause mortality. So that's why, it's not just to reduce the replication. It does have mortality benefit, just like dexamethasone does. And by the way, the study I showed you with dexamethasone, remdesivir was not on the market, so none of those people had received dexamethasone. Now, this is the remdesivir, right? So one thing you can look at with the subgroup, so when they looked at ventilation and baseline, those who were on non or low oxygen, they had mortality benefit. But here, this line is people who were on, what does it say? High flow or non-invasive mechanical or ECMO, okay? So if they had advanced oxygenation needs, it doesn't look like it reduces mortality. And that's exactly what they said. The virus is not there. Remdesivir is not going to do anything. So they have shown that you're not going to get any benefit out of remdesivir. So having said that, let's now switch gear to some of the VTE issues. So again, this patient, you guys decided to give her dexamethasone, tocilizumab, and remdesivir. What about VTE management? Hopefully you guys remember your heparins from cardio. Have you seen them since cardio, or which course is using these agents? You'll probably see them in pharmacy practice. Right? Is pharmacy in any pharmacy practice going on? It's all next block. Okay, you will definitely see these in pharmacy practice. So let's do a review. You got to figure out which one is for. And I just put this for discussion. You don't have to remember anticoagulation dosing for this course.
Well, it's just straight 5,000.
Yeah.
have anything to do with that?
It was asking for
Or that?
on the.
No.
No?
It says
Just
pathological.
preferred.
You're also assuming there is a preference.
Huh?
You're assuming there is a
Oh,
preference.
there isn't?
I don't know.
I think I. Oh,
So assume normal renal function. Normal renal function. You definitely have to deal with this on APP rotations. It comes up every day. Or you may have showed up on your IPP, I don't know. Are you guys ready? Okay, 1, 2, 3. Two hands if you say G. One hand and C. So I see C and F. C and F. Okay. I personally like C because if this person has COVID, do you want the nurse to go in the room 3 times a day or once a day? Right? But yeah, if you did C, so one thing is, let's take a step back. Does this patient, why not pharmacologic thromboprophylaxis? Why is H wrong? This patient has an acute illness that's highly inflammatory, right, which can trigger VTE, so definitely need something, right? So you don't want to do H, within reason. There are always you always have someone has active bleeding, whatnot. So assuming there is no contraindication to anticoagulation, always look for contraindications for anticoagulation. Someone is having hemorrhagic stroke at the same time, don't give them anticoagulant. But assuming there are no contraindication, this patient definitely qualifies. The question is, therapeutic dosing or prophylaxis dosing. So high flow puts it outside of the therapeutic dose, right? So if it was low flow, patient will qualify for a therapeutic dose. Therapeutic dose essentially would be 1 milligram per kilo of enoxaparin twice a day, right? Or alternatively, like 1.5 milligram per kilo once a day. For this, you want to do prophylactic, right? So, and there is some controversy on this, right? based on body weight. Now, this patient had normal body weight, so you either do like 40 milligram every 24 hours, or if you do unfractionated, it's 5,000 units every 8 hours, right? So what I have bolded is what most people have agreed on, right? The rest of this is a little controversial, and what is in this table is probably most reasonable people will agree, based on body weight, because people have tried different things in, obesity, and also something a lot of people forget to talk about is what to do in people who are underweight. Okay, so unfractionated heparin is easy as far as, it's not affected by renal function. Okay, but people will get injected 3 times. This drives me nuts when I see doctors like, oh, we always do unfractionated. Some people will say, we always do unfractionated heparin, so I don't have to think about the renal function. I'm like, so you are doing sub-Q injection on someone 3 times a day because you don't want to think about renal function? That's, imagine you are very sick, you're trying to get some rest, and somebody comes to poke you 3 times a day because somebody doesn't want to think about renal function. So in general, I'm like, if you can, I prefer doing once a day, right? Not to mention this patient has COVID, so you're going to expose someone, the nurse, like 3 times a day, right? Now, this one should be avoided in dialysis patients, but you can dose adjust in creatinine clearance less than 30. Let's see, what else? Obesity, there's some controversy because people have tried different doses. There's no clear conclusion. So, I have put this here. People have agreed that 40 milligram 2 times a day might be appropriate at BMI over 40. And at extreme of body weight, you may actually need to do per kilogram dosing. When it comes to this is where I prefer unfractionated heparin because this makes me nervous. These are very higher doses, so people could bleed. So at least here, nobody has proven that you need higher doses than this. So I tend to go to unfractionated heparin for extremes of body weight, but it's a bit controversial. So you're whatever your preceptor tells you, right? So you have to do what your preceptor tells you, and later in life you can decide for yourself what doses to do. So for this patient, I would say either if you did what did we say, 40 milligram every 24 hours. Or if you want to do 5,000 units sub-Q every 8 hours. Okay. Another thing that comes up on rotation is like these are sub-Q, not IV. Right. This comes up a lot when student comes and recommends IV. 40 milligram enoxaparin IV every 20. It's sub-Q. Okay, we talked about this, and then one last question is. We started that treatment, but this patient actually is on mechanical ventilation now. It actually, she needed more oxygen. We had to put her on mechanical ventilation. So what do you recommend now? Should we make adjustment to the treatment? Okay, let's see what you guys got. 1, 2, 3. Looks like everybody says E, so you guys dropped remdesivir, right? So at this point, if the patient is sick enough to be on a mechanical ventilation, you're very advanced in the disease course. It's unlikely that the virus is replicating there. It's the immune system in cytokine storm, severe cytokine storm driving this. So you drop remdesivir, and studies have shown there is no mortality benefit to remdesivir when the patient is at this stage of the disease. And remdesivir is not free, right? If there is no benefit, there is no reason to give it. There's cost associated with it, and there are always adverse effects. So, what question do you guys have? Good. Is COVID easy to? Was this an easy topic? Okay. So let's talk about some prevention measures. I say prevention because it's not just vaccines. Okay. So there are monoclonal antibodies. By the way, tocilizumab is also a monoclonal antibody, right? But we don't necessarily, when we talk about monoclonal antibodies for COVID, we're not talking about tocilizumab, because tocilizumab we consider it interleukin-6 receptor antagonist. Okay, so we're talking about literally neutralizing monoclonal antibodies. So remember, when the virus comes in, it wants to bind to the H2 receptor. If you have monoclonal antibodies, they will bind to the spike protein and neutralize it. So that means it cannot bind to the H2 receptor. Now, why is it important? Because certain people, like severely immunocompromised patients, may not respond to the vaccines. So they may not have antibodies. So this is a way of passive immunization, right? So you literally inject the antibodies because their body could not make it. That way, in case and this is for prevention, it's not for treatment, right? So you inject the antibodies so that if one day they get exposed to it, they have antibodies ready to go. So we only have, I was actually going to make, I almost made a slide and called it monoclonal antibody graveyard, because we've had a ton of, well, not a ton, 1, 2, 3, 4, 5, 6, maybe 6 or 7 monoclonal antibodies that came to the market and went off the market in the past 4 years. We only have one on the market right now. It's EUA. Okay. The problem is, as these mutations happen to SARS-CoV-2, they lose activity because it's just monoclonal antibody binds to just one region of the spike protein. If that region mutates, it no longer binds. Okay. So everything that came to the market previously no longer works with what's circulating. So they're all off the market. And you may have Regeneron was famous because that's what Donald Trump received when at the time he was not on the market. So when he got COVID in 2020, they want to give the best to him. So they actually gave him an injection, and it worked pretty well. But anyway, Regeneron came to the market, and it's off the market now because it doesn't work anymore. Okay, so we have Pemgarda, Pemivibart, that's on the market, came out earlier this year. And the half-life is pretty long. So you actually do one injection every 3 months. So it's good. Whereas some of those initial monoclonal antibodies did not last that long. Now, when monoclonal antibodies, just similar to convalescent plasma, you're going to have infusion reaction. So first of all, you need to infuse it very slowly, or people are going to react to it, right? So it's a 1-hour infusion. And then you got to observe people for 2 hours. So it's not convenient. That means it will take 3 hours of your time if you are to get this infusion, because you're sitting there for an hour for the infusion to go in, and then 2 more hours for people to watch you to make sure you're not having anaphylactic reaction. And then at the end of 3 hours, you go home, and you'll repeat in 3 months. Again, this is just for certain populations like severely immunocompromised, and on their website they have resources to identify like an infusion center so you can connect people. That's all you need to know about this. and it's for pre-exposure prophylaxis. Okay, so this is before somebody is exposed, you inject it, and IDSA guidelines has recommendations for who should get this. So they say for moderately or severely immunocompromised individuals as risk of progression. So some of those risks that we had talked previously. Now, if somebody received vaccines, it should be at least 2 weeks after their vaccines, because you don't want this to interfere with the immune response to the vaccine. Risk of anaphylaxis in general is pretty low. So it's 0.6% risk, but because people die from anaphylaxis, you don't want to just send them home. So you do watch them for 2 hours. Now let's talk about vaccines. Okay, don't worry about this. The point of this is to show you different technologies of vaccines, how we make vaccines, because with COVID, we had new technology come to the market. So in general, you can think of when there's a virus and we want to make a vaccine, we can actually take the virus and make it weakened. So this is what we did with flu mist, right? So it's the actual flu. We weakened it so it's not going to give you the flu, but it can replicate. So in the case of flu, it was not injection, it's a mist in the intranasal. But that's one way to make vaccine. Take the virus and weaken it and put it in somebody so the immune system sees it. The second is inactivate. You just, they don't like to say kill because viruses are not living organisms, but essentially that's what you're doing. You kill it, you inject it, the immune system will see it and develop immunity, right? And that's what we do with inactivated influenza vaccines. The next one is actually a couple of vectors, right? One is replicating vector, the one is non-replicating. What is a vector? They're essentially saying we took another virus that doesn't do harm to you, it's a virus. We're going to put the DNA or the genetic material of, in this case, like the spike protein. We engineer this vector and we inject it to you. And as it replicates in the body, it's going to make the spike protein, and then your immune system will see the spike protein and will make antibodies to it, right? So we did have some vectors. So the Janssen vaccine, the Janssen is owned by Johnson & Johnson. So it's, some people will call it Johnson & Johnson vaccine, which is no longer on the market, by the way. But that was the technology they were using. They found, they were using a benign virus as the vector for the gene for spike protein. And then next is protein subunit. So if it's the spike protein that your body needs to see to make antibodies, why don't we just engineer some of the spike protein and inject you with that? And that's how the Novavax vaccine works. Novavax, and this is how Flublok, right? Flublok for the flu. This is recombinant, so they inject you the actual proteins. And I'm going to skip this one because we don't have anything. And then the newer technology is the nucleic acid, right? So there are 2 different ways to do this, right? Either inject DNA into you. So if you inject DNA, the DNA will go into the nucleus and it's part of the host nucleus. And then the cell replicates and will make those proteins. So if it's a spike protein that was included, so if the gene for spike protein was included in DNA, it will work. That is not what we did. Instead, they did the RNA vaccine. So mRNA essentially is the blueprint for the spike protein. You inject it into the muscle of the patients. The mRNA will find the ribosome and will translate into the spike protein. And then once the spike protein is built, then the immune system will see the spike protein and will make T cells and antibodies against it. So that's how these vaccines work. And this is what you actually need to know. So we have 3 vaccines on the market. And most people refer to them by the manufacturer, right? The Pfizer. Technically, Pfizer did not make it. There's a company called BioNTech. Some people say BioNTech. It's a German company. They're actually the ones that make it, and Pfizer partnered with them, and Pfizer is manufacturing it. The second one is Moderna. It's a small company in the US. And the third one is Novavax, okay? And then Janssen is off the market. So Janssen used the vector-based. it can cause like, what was the adverse effect? Is like, some sort of stroke. So they took it off the market. So it's rare, but because of adverse effect, they took it off the market. Okay. Pfizer and Moderna, they use mRNA. Now they do update it annually. So for 2024-25, they have put the KP.2. Remember I showed you earlier all these circulating. So they put KP2, which is no longer circulating. Thank you. These are descents. Here's KP2. It's 2% of what's circulating is KP2. Okay, that's in the vaccine because these things are changing. So if you try to target, in fact, Novavax has JN.1. So Novavax is a protein base. It's just like the flu. So you know how we make the flu shots? We have to do it like ahead of time before we know what's circulating because it takes. To make these protein vaccines, it takes time. They need about 6 months to make them. So that's what Novavax does. In fact, they use what do you call this? Sure. That's what they use. Don't tell patients. They will not get the vaccine. But essentially, they put the gene in this bug. It will produce. I know. I should not have showed you this. Sorry. Knowledge is power. Sometimes. I don't know. But anyway, that's how they do it. So they put the gene in this, and then it will make the protein, and then they will purify it. I should not tell you the dyes that Starbucks puts in there. Anyway. So they decided, so when FDA earlier, they decided that it should be JN1, and then soon they were like, oh my God, JN1 is no longer circulating, it's KP2. They cannot just change it on the spot. So they stay with JN1. mRNA is easier to update and manufacture. So that's why it's a good technology, mRNA. So they were able to update it. So they didn't do JN1, they did KP2. So it's actually more updated than this. But even KP2 is no longer, it's like 2% of what's circulating. So, but it's okay because it doesn't mean that it's not going to work. So, there is some cross-reactivity between these different variants, okay? Now, they all do the full length of the spike protein because some vaccines were trying to do just regions of the spike protein, like the receptor binding domain, but they all do the full length spike. They're all stabilized in the pre-fusion form, okay? And that's why they are pretty good effective. Like if you had heard of the AstraZeneca vaccine that they had in the UK earlier, it didn't work very well because it was not pre-fusion. They did post-fusion, and the efficacy was not as good. So, and it never made it to the US, and nobody's using AstraZeneca's anymore. Now, these are FDA approved for adults for sure, but age 12 plus. For under age 12 is actually EUA, and this is EUA for everybody. So 12 plus is EUA. Let's see what else. So these two are similar technology. This Moderna uses a higher dose. In fact, initially they were using 100 microgram. They always did 30 microgram for adults. For children, it's a different dose. But they initially did 100 microgram, but it caused more adverse effects. So specifically myocarditis was higher with Moderna. So they actually cut it down to 50%. They're all IM. Initially, they had to be super frozen, right? There was like a vial. I don't know if you guys received the vaccines early in the pandemic. There was those vials that had to be in negative 80 degrees or something because it's difficult to make mRNA stable. Nowadays, they have mastered it now. It's pre-filled syringes now. So it comes in the fridge. You don't have to keep it in the freezer. So it has improved significantly since COVID started. And what else? I think this might be my last slide. Oh, I have one more slide. The recommendation. Simple. Everybody recommended to get one shot annually. Okay. Now, if somebody is immunocompromised, they may need an additional dose depending on whether they had previously had full vaccination or partial, right? So if it's partial, it just depends on how many they had received. But essentially, everybody just a single shot, and that's all you need. I think this might be the last one. Yes. So what question do you guys have about vaccines? Yes.
Is there a potential for, because you mentioned that COVID causes overall inflammation,
Uh-huh.
could the proteins that are coated from these mRNA vaccines have any potential for overall inflammation?
Well, the mRNA definitely has caused myocarditis in a certain. So myocarditis is inflammation in the heart, right? Now, I will say, so there is certain age group that are higher risk of myocarditis, right? Specifically, men in their early 20s, right? So those were the people who were more likely to get myocarditis with the second dose. So because initially, so remember the first time this got rolled out, the first time you guys got vaccinated, it was a double shot, right? You got the prime boost, so you got your prime, and then the boost was either 3 weeks later if it was Pfizer, or you got 4 weeks later Moderna, and the myocarditis was happening with the second shot, which now they think is because the second shot was too close to the first shot. So if anybody's getting vaccines for the first time, you usually tell them to do it 8 weeks later instead of 4 weeks, and then was not there for the third shot. So yeah, so it's not really causing, so myocarditis is one thing that's known, but it's not really causing any other issues. And myocarditis is rare, so even though we talk about myocarditis, it's extremely rare. It's not reason to not get the vaccine. Other questions? Have you guys administered the COVID shots? Any questions about this topic? Well, thank you. Please, oh, we finished on time. Thank you. Please make sure I get the response cards back. And there is IDSA conference going on. I'll be gone the rest of the week. IDSA conference, we call it ID week. And so there's no class on Thursday. And we'll see you on Monday. And I haven't graded your aminoglycosides yet, so I'll probably grade them next week. Do you not expect 100 if I grade it?
I do.
We can see if the guidelines change.
Which guideline?
Because I know that we came back from ACCP, and the guidelines changed for HRS.